Good morning, Paramedic Pat here with another story. Actually, it's a couple of different little stories all put into one. But what I'm going to talk about today is monitor defibrillators and kind of the evolution of them as far as what I used on the ambulance. Way back in the late 70s, kind of a go-to piece of equipment as far as a cardiac monitor and a defibrillator for ambulances and emergencies was called an MRL. And this piece of equipment was housed in what we call a Halliburton case. And that's an aluminum case that can be modified to carry all sorts of things. But in this case, it held the monitor, the tape writer, the paper writer that actually gave you a printout of the heart rhythm, and also had the defibrillator in it. And it weighed 40 pounds. It had a big handle on it, and you carried it like a piece of luggage. It was a couple of feet deep, a couple of feet, not feet, but about 2 feet deep, maybe a foot and a half wide, maybe a little bit less than that. But it was a fairly good sized piece of equipment. But it was all we had at the time, and it worked. If you remember in some of my previous videos, I talk about the little boy Lee, and I talk about cardioverting him. And I was using the MRL the day that I did that. My other video is about the first full arrest that I converted. I was using the MRL that day. So even though it was heavy and bulky and everything, it did its job. But it did have its drawbacks. The battery didn't last very long. In fact, it used a motorcycle battery to power it. And that was always kind of funny to us that the piece of equipment, they used an actual little small lead acid motorcycle battery. Well, things evolved, and a company called Physio Control made what was called lifepacks, and they numbered them in the sequence they built them. There was a lifepack 3, 4. I never saw 1 or a 2. I know I saw 3s and 4s. But the one that hit the market that was really kind of revolutionary was the lifepack 5. It was the first kind of compact, easy to carry monitor defibrillator. And I'll throw a picture of that over here too. And it could be taken apart to where you just had the monitor. It was real light, only weighed a couple pounds. Or then you had the defibrillator as a separate piece of equipment. And each would supposedly work independently of each other, but most people just locked them together. Now, if you're just monitoring the patient as you carried them upstairs to the hospital or something, you could take it apart and just take the monitor apart to where it wasn't as heavy. But it was a great piece of equipment. It didn't have a lot of extra bells and whistles. It had a 3-lead, could do a 3-lead EKG, and you could cardiovert people. It had the synchronizer on it. But it was its only drawback was the batteries. They were rechargeable NiCad batteries, and you always had to carry several of them, especially if you were really heavy on treating cardiac patients that day. The batteries, as they got older, wouldn't hold a charge very long. So you'd swap them out and go in, and we usually had several chargers going at once, and you'd grab your old batteries from the shift before if you came on shift and grab a bunch of 5 or 6 new batteries that were fully charged and take them, put them out in the unit. But it worked. We used what we had available, but it was a lot lighter, and it was a good piece of equipment. It did what it was supposed to do. The third monitor defibrillator I want to talk about was a LifePack 12. They evolved and evolved and evolved, and what made the LifePack 12 different than the other ones I had is it had pacemaking capabilities. And when we first got that piece of equipment, I kind of thought, well, when are we ever going to pace somebody? I'd never had a patient with a heart rhythm that needed pacing. But it was on there. Now, it wasn't quite as small and compact as the LifePack 5, but it had a lot more capabilities. You could do a 12-lead EKG on it with it. It would hold it in memory. It was a pretty advanced piece of equipment. And we started carrying that in the late 90s. And had it on the unit. I don't know, I guess we'd had it on the truck a couple of months. And one night we got toned out to a possible cardiac problem. And it was part of our territory that was very rural, a little bit of a ways away. Now, as I've talked about before, we had first responders back in the days when that's what they really were. They were EMTs, a lot of them attached to fire departments, volunteer fire departments. And they would be toned out also. The dispatcher would look and say, well, we've got John and Jane here, and they're close by. Let me page them out and let them go out and check the person and start treatment before the ambulance gets there. It was a system that worked real well. But anyway, we're rolling out to the unit, and we hear Kathy, one of our first responders, one of our good first responders. They were all good. Some were just better than others. Kathy was really good at what she did. And we hear her go out on location. We're still probably 7-8 minutes away. And we finally find the place. Of course, it was out in the middle of nowhere in the woods at night, but we found them. And we see her car, Kathy's car, sitting there with the trunk open. She'd always throw the trunk open and grab the stuff she needed and go on in the house. Well, as we walked in, this man, we saw him laying on a hide-a-bed, one of those old sofas that you could fold out, make a bed out of, and it was folded out into a bed. And he was very skinny, very emaciated looking, kind of tall. They always look tall when they're skinny like that and they're laying on a bed. It always looks bad. He was gray, pale color, did not look good at all. And Kathy had just got through taking the blood pressure, and she kind of turns around and she reaches up and takes the stethoscope out of her ears. And she goes, well, Pat, I got like 60. I heard a sound at 60. I don't know if it's accurate or not. Here, you might want to try it. So as I grabbed the stethoscope and put it in, Karen has got the monitor, the LifePack 12, and she's hooking him up to it so we can see what kind of arrhythmia he's in. Well, I take the blood pressure, and at 60, sure enough, just like Kathy said, at 60, I heard thunk. I saw the needle bump, and that was it. I'm like, oh, that's not good at all. Well, by then, Karen had the monitor up and running. And for the first time on an actual living person, I saw that he was in a full 3rd-degree heart block. Now, it's not a heart block of an artery. It's a heart block of the electrical signal. And what happens is that normally your atrium, the top part of your heart, the 2 small chambers, left alone, they'll beat at 60 beats a minute or so. And your ventricles, if they're left alone, they'll beat at about 20 beats a minute. Well, normally an impulse starts at the top of your heart, and it shoots down. It makes the atriums beat, and it goes down through this nerve bundle called the bundle of His. It goes to the ventricles. This is all done in just a microsecond, and it makes them beat. If that electrical signal is interrupted, the atriums are going to beat at the rate called intrinsic rate of 50 or 60, which they were doing. And the ventricles, unrelated to what the atriums are doing, are going to go, well, we're not receiving any signal, so we're going to beat at our normal intrinsic rate of 20. And that's exactly what this man was doing. Well, since the ventricles beating is what actually sends the blood through your body to keep it alive, that's not enough to really keep you alive for very long. And that was that thump I heard. And it was clear on the monitor he was in a full heart block. A perfect patient to use the pacemaker on. Now, I never thought I would use the pacemaker in the field, and I had never needed to use one before. But here we were, we had the right equipment to help this man while we transported him to the hospital. So we go ahead and get him out to the ambulance real quick where we had everything we needed. Now, back then, our protocol said that if we had a patient with a very slow heart rate, that we were supposed to give them atropine. And it didn't make a differentiation of why it was slow. So to follow protocols, I gave them an amp of atropine. And I knew it wouldn't work, and it didn't. By then, Karen had the pacemaking paddles out. And they were the sticky kind. They were about maybe this big around, or rectangle. You peeled the backing off, and you put one up here on the right shoulder. And then you put one down here on the left side, and that's so the current can go through the heart. And I turned on the pacemaker, and I set it to a rate of 70, since that's about the normal rate of an adult heart. And you've got another little rocker button that you can push to add more power to the electrical impulse. And you slowly push it up and increase the voltage or the current until you get what we call capture. And that's where that signal is making, that electrical impulse is making the heart beat. And sure enough, I got to a point and all of a sudden I had capture. You can see the little spike on the monitor, and right afterwards you can see this wide complex, QRS complex. And that was the ventricles beating. You reach down, you feel for a pulse. You can feel it beating. What once was, you could really not feel his pulse, now you can feel it. So we had done what we could for the man, and we take off to the hospital. What is funny is that the patient will actually jump, or the muscles in his chest will jump at the rate that the pacemaker is set at. So if you have it 70, this patient is actually going to be on the ambulance, and they're going to, on the stretcher, and they're going to go at about 70 times a minute. No one told me that was going to happen. I didn't think about it. But it's what you had to do. He was unconscious. He didn't really feel it. But we get him to the hospital. It's about a 15-minute trip. And we had radioed we were coming in, but this hospital always seemed to be surprised. No matter how many warnings we gave them we were coming, they always seemed to be surprised. Well, the head nurse was one that, oh no, she kind of always had this now what look on her face whenever we walked in with the patient. And she could be a bit cantankerous at times, but oh well, we always got the job done. So I walk in, what do you have? Well, he's being externally paced. We need to have you to go get your pacemaker so we can do a swap over. Because the protocol then was once you started pacing someone, you didn't stop. And all the ERs back then had a little small device, looks about the size of a cell phone, maybe a little bigger. And it was just a little pacemaker. The plugs on the pads that we had on him was a universal plug. All she had to do was turn it to the rate and the amount of power we had. I'd unplug it from my monitor, plug it into her machine, and it would continue on. She just put him over on bed, whatever. Can you go get your pacemaker? I'll get it in a minute. And she kind of shot back at me, and I'm like, I'm not leaving the patient without him being paced by your machine. I told you I'd get it in a minute. And I said, I told you I'm not leaving him unless you're pacing him. I did raise my voice a little. Luckily, the ER doc was close by, and he heard me raise my voice and her raise her voice. He comes over there and asks what in the world's going on. I told him, I said, this man's on our pacemaker. I asked her to go get her pacemaker so that we could transition the patient to your care. The doctor looked down at her and says, go get the damn pacemaker. So it was obvious, I don't know if he'd been having trouble with her already that night or not. She reluctantly went and got the pacemaker, and then didn't seem to really know how to turn it on and use it. So the doctor took over, and we made a effortless transition to their pacemaker and moved the patient over. But we found out this man was a Vietnam veteran, and that he had been exposed to Agent Orange. And that was the cause of his problems, his medical problems. I also understand that they went ahead and, of course, put a permanent pacemaker in him. And with that, he was able to return to pretty much a normal life, and was able to get up and get around. And apparently before that, he wasn't able to. But apparently it made a world of difference in his life, and was able to get up and do things that he'd always wanted to do. So that was good to hear. So that's the story, kind of the evolution of the monitors and defibrillators that at least I was associated with in my time. But anyway, that's my story about the evolution of monitor defibrillators and actually getting to pace someone and make a difference. And that was always a good thing to happen. Well, all right, that's my story today, and I'm sticking to it. And we'll catch you next time.